All right, cool. So, guys, we're going to talk about hemodynamics today. And admittedly, this could be a pretty complex topic. And so I want you to know that if you don't get every little detail during this lecture, right, that is not a failure on me. That's a failure on you. All right. So as long as we all start from a safe place. No, honestly, if you don't get every little topic right now, that's fine. That's totally fine. What I care more about is that you understand the ideas behind it, right? Because we're going to move on to things like aortic valve and mitral valve in the next few weeks. And if you don't understand kind of what the term gradient means, or you don't understand how we're using some of the changes in pressures across valves to figure out different pressures, different velocities, you're going to have a hard time understanding that stuff. So don't focus on memorizing, how you calculate a PA diastolic pressure today. That's going to come as you do more scans. But try to do your best to recognize what we're actually talking about and the physiology behind it and the reasoning behind all the stuff that we're doing. All right, so this is the famous Bernoulli here on your left side of your on our right side of the screen, and we're going to be talking about him. But I figured I'd put a face to the name.
Looks like my Kouch though.
Yeah, it looked very similar to me. But he's a cool dude, and we're going to do some cool stuff today. So that's the only funny feature in this lecture, so it's all downhill from here. So we're going to start talking – we're going to do two different topics. We're going to start talking about cardiac output, and then we're going to talk about gradients, right, and how we calculate pressures in chambers based on gradients. So let's first start talking about cardiac output. So cardiac output, what does cardiac output equal? It equals stroke volume times heart rate. So we have to figure out a way to calculate stroke volume because we already know the heart rate when we're at the patient's bedside. So when you're calculating cardiac output on an echo, you're not actually calculating cardiac output. You're calculating what the stroke volume is, okay? And so this is pretty straightforward. Doesn't take a lot of equations to do it, and you all probably know how to do it, but the reasoning behind it, you probably don't quite know. So stroke volume, basically all we want to do is find out the area of this cylinder right here, okay? So the area of this cylinder, right, is how much volume is being pushed out of the left ventricle, or right ventricle eventually when we talk about that, in one heartbeat. That's all we care about. We just want to know what is the volume during that one heartbeat of blood that's moving from the left ventricular chamber out of the aortic outflow tract, okay? And that's how we calculate stroke volume. We are then going to multiply that by our heart rate, and that's going to give us our cardiac output. So what is the volume of a cylinder, right? The volume of a cylinder is the area of the base of the circle, which is this area here, calculated by the height, which is here. Okay, and so this is very, very easy to calculate. So the area of a circle is what? Pi r squared, right? And so we measure the diameter of the aortic outflow tract, and we'll show you on our next images on our parasternal long axis view for the most part, right? So we already have this radius. So we just divide that diameter by 2, and now we have our radius. Now the question is, how do you calculate your height, right? And so really, we're just using something called our VTI, right, our velocity time integral, to calculate the height, or basically the distance that red blood cell is traveling during that heartbeat. That's all we're doing. The VTI just means this is how far this red blood cell that we're measuring, right, or this group of red blood cells, traveled during one beat, okay? So therefore, if we want to calculate our our stroke volume, we're going to do pi r squared times our height, which is our VTI, okay? So if you just remember, keep it really simple, that the VTI just means it's the distance that is traveling in one beat, all right? Does that all make sense? Good, okay. So here's just a catch-all slide of what you're going to be looking at when you're calculating cardiac output for a patient. So here we have a parasternal long axis view in the upper part of our screen, right? And we see our left ventricular outflow tract that's marked LVOT, right? The place that we want to measure is just proximal to the aortic valve leaflets right here, okay? And we want to try to measure as perpendicular as we can to the actual direction of the left ventricular outflow tract. If we are measuring at a different angle, we're going to overestimate, right, our diameter, and that's going to really alter our cardiac output, because our diameter, right, is how we get our radius, and then we use our radius squared as a major component of this calculation. So every millimeter of change of incorrect measurement that you make on this aortic outflow tract is going to be squared, right? So that's the biggest mistake that you can make, is over or underestimating your left ventricular outflow tract, right? And so let's say, for an example, you over measure or under measure by 2 millimeters, right? That's not a lot of space. You're going to actually over calculate or under calculate by 20% your cardiac output. So when you're measuring this, you're getting your parasternal long axis view, I want you to zoom in on this area here, right? Which is going to help you place your calipers for measurement, but it's also going to limit, it's going to direct all those ultrasound waves into that specific area and give you a more clear picture, right? So it's very important that when you get your parasternal long axis view, make sure you get a very good view. Make sure you're measuring see how this is the opening of the aortic valve right here? You want to measure it during systole, and you want to measure perpendicular perfectly, just proximal to these valves, right? So I know this is a simple thing, but I can't harp on it enough, that's going to be your major incorrect measurement if you're over or underestimating cardiac output. And that will be on your board exam, right? That idea of the importance of measuring the tract distance. All right, so we get our measurement here. We divide it by 2, and that gives us our radius. You multiply that by pi, and that's going to give us the surface area here. That's going to give you the area of the base of the circle of that cylinder. And then all we have to do is calculate that by the distance that red blood cell traveled in that second, right? Or stroke distance, some people will say, right? And that'll give you part of your cardiac output, and you multiply this all by your heart rate, and that's it. So very, very straightforward, okay? Here is a parasternal long axis view. So where do we get our VTI and how do we do it? So basically we're putting our pulse wave Doppler down here at the same position that we measured. We'll go over that in a few minutes. And that's going to give us this image down below, okay? Now, some of us last night were talking about it. What's very important about the shape of this VTI? How do I know I have a very good VTI measurement? What does it look like? If I had to show you, does it look like this? Does it look like this? Which would be better? Option 1 or option 2? Option 1. Why was option 1 the flow that you want to get, the pattern?
Flow.
Because it's laminar flow, right? So we talked about this very early in our lectures, that if you have a red blood cell going through a vessel, you want all of the red blood cells traveling at a similar velocity. So as we go along this path here on the bottom of the screen, that's time, right? Time is on the x-axis. So you're measuring instantaneous Doppler velocity of a red blood cell at time 1, 2, 3, 4, okay? And if you have all of the cells traveling at the exact same speed, you're going to have a very dense mark at that area. But if you have a bunch of red blood cells traveling at different speeds, so at point 3 here, they have some going slow, some going fast, this area is going to be filled in. That envelope, as we call it, is not going to be hollow anymore. And so that's showing you that you have probably not laminar flow. So either there's something within there, there's some subvalvular apparatus that's causing a more turbulent flow, or maybe you're measuring up against the wall, and so you may need to readjust your position or get a better image. So those are the important things that are going to go into the measurement of your VTI. All right. So when we're measuring cardiac,
if you're doing pulse wave, where do you place the cursor?
So we're going
Just after, okay.
Yeah, so right here, if you see right here, I want your cursor to be placed exactly where you measured your diameter, right? That's very, very important, because let's say you have a narrowing area just distal to where you measured, as we are going to show later in our Bernoulli equation, that's going to alter the velocity. So where you measure your distance is exactly where you want to place your pulse wave Doppler, which is just proximal to your aortic valve leaflets, right? Your left ventricular outflow tract, not necessarily in your aortic valve. Does that make sense? Okay. All right, so there are three major errors that we're going to make in this, okay? The first is angle. And why is that? We talked about this earlier in our other lectures, right? That we want our angle, we want the red blood cell to be going directly towards the probe or directly away from the probe, right? And that's how we're going to measure our Doppler. Because if a red blood cell is going in this direction and I'm measuring the Doppler velocity like this, right? The actual Doppler velocity is going to be a cosine of this angle. So once I get over 20% of angulation, I start to have gross abnormalities in the true calculation of that Doppler velocity. Okay, so the angle is going to be of utmost importance. So you want to get that left ventricular outflow tract as vertical as you can, and you want to place your pulse wave Doppler in that area. Okay, the second error you're going to find yourself making is in the diameter that we spoke about, right? So if you underestimate your diameter, you're going to grossly under or grossly overestimate your cardiac output because you're doing your radius squared. So every abnormality you make here is going to be squared now. And then the last, as Brian brought up, is location. So we want to measure at the exact same location that we measured our diameter, right? Our pulse wave has to be in the same position as where our diameter was. So a great example of this is if someone is checking, and we'll talk about this in a later lecture, but volume responsiveness. And you give someone some fluids, but prior to giving fluids, you checked a left ventricular outflow tract VTI. And if they're fluid responsive, we want them to have improved their cardiac output, certainly over 10%, right? Some people will say higher, 13% is kind of your magic number. So if you are measuring at different places where that left ventricular outflow tract is either wider or narrower, that's not going to give you a reliable calculation as did this person's cardiac output improve with fluid. And so it's the same idea that you want to be measuring at the exact same place. Okay? All right. So we're going to move on. This is a really cool image. This is your main pulmonary artery right here. Okay? And this is the break off into your left and right pulmonary arteries. Okay? So you can do the same thing in measuring your right ventricular outflow tract and your right ventricular outflow VTI and calculate your right-sided cardiac output. And why does that matter? What are a couple instances where you would have differences in your left ventricular cardiac output and your right ventricular cardiac output? Pulmonary hypertension. I guess technically you could if you're decompensated and you're backing up and now you're causing other left-sided failure, et cetera. But for the most part, the amount of volume that's under normal conditions going out of your left side and going out of your right side should all be equal because you have it's a continuous plumbing system, right? Unless volume gets lost somewhere. So shunting, right? So whether that's a VSD or a patent ductus arteriosus, right? That's going to cause changes in flow. Pulmonary embolism? Why would that be?
Well, if it was obstructing.
Well, again, if you're causing backflow, I guess theoretically you could, but for the most part, you should have continued flow going. Because you're right, you're causing backup of flow, now interstitial edema, et cetera, on the left side. So, but you should normally have pretty similar flows unless you're decompensated, like you're saying. Aortic regurgitation, right? Let's say I have a large cardiac output, but then I'm backfilling into my aorta, right? So my flow out of the aorta is going to be a lot early. And then during diastole, I'm filling backwards into my left ventricle, and that's causing my stroke volume to be even higher at the next beat, okay? So you can do the same thing. Now, let me ask you a question. Let's say our left ventricular cardiac output is equal to our right ventricular cardiac output. We don't have these problems present. would the VTIs be this? Can the VTIs be different in these two? They can be different. And why can they be different? Right. If your outflow diameter is different and you have the same cardiac output, then your flow must be different as well. Right. And this is going to be a good transition over to Bernoulli's equation. So if I have a vessel that's this big and I have a vessel that's this big, right? Is my velocity going to be faster through this one or through this one? Right. It's going to be faster through this one, through the smaller one. Right? Because it's got to maintain that same output, the same amount of total energy through that vessel as this vessel if it's a closed system. And therefore, you're going to have a faster velocity through these smaller chambers. And that's going to be really important when we move forward and we start talking about vessel sizes and trying to see somebody's true aortic stenosis severity, et cetera. Okay, so it's a good important thing to remember. All right. And then the last thing before we move on to gradients is I want to talk about something called QP and QS. And this is something that you're going to see a lot in congenital diseases, like patients who have, patent ductus arteriosus or anatomical shunts. This is the flow through your pulmonary system compared to the flow through your systemic system. And they should be equal to 1, right? If you have a QP that's greater than a QS, so the flow through your pulmonary system, right, is greater than the flow through your systemic system, what kind of shunt is that going to be? It's going to be a left to right shunt, right? Okay. If you have a QP that's less than your QS, are you going to have a left to right shunt or a right to left shunt? Right? It's going to be the opposite, right? All right. And that's just, I want you to know what that term is. If you read it in questions, it will come up in a few questions. But if you just simplify it like that, very, very easy. Okay. And we're going to go over a little bit of a complex form of this in one of the questions, which I'm expecting you guys to get wrong because it's a setup for a trick question. So that's a hint, and maybe you'll get it right because of that. All right. So now we're going to move on to gradients, right? So this is, the Bernoulli equation up in the top of your screen, and you do not need to remember this. But I want you to understand what goes into the Bernoulli equation and what the theory behind all the Bernoulli equation is. So let's see here. All right. So in the Bernoulli equation, this is the only part we care about, is the convection acceleration. The flow acceleration should be stable. The viscous friction component should not impact anything, okay? So we're only going to be focusing on this convection acceleration, and we're going to show a derivation later about how you come up with the modified Bernoulli equation, which is what we do. So the basic idea between the Bernoulli equation is the law of conservation of energy, okay? So you have kinetic energy, which is your K, and you have pressure energy, which is your P. Okay? As blood is flowing through this chamber, right, the kinetic energy and the pressure energy combination, so the total energy of this system needs to be the same at point 1 and at point 2, right? Energy cannot be lost between, right? It's all conserved during all of this, right? And therefore, it can be transferred from K to P or from P to K, right? And that's all we have to remember, that during this entire system, the energy will be the same. So just like we spoke about in very clear terms, that if you have a lower pressure system or a higher pressure system, your velocity is therefore going to have to change depending on that. And that's dependent on the volume of that system in general. So if you have a big, big chamber with a normal amount of blood, is going to have a lower pressure system, versus you try to squeeze all of that volume into a smaller chamber, right? Your velocity is going to be higher as well, right? So very, very important here. So basically that K1 and the addition of K1 and P1 at point 1 here has to equal the combination of K1 or K2 and P2 at position 2, right? And that's all Bernoulli equation is showing us. So if you look over here on the right side of our screen, here's an example of flow through aortic stenosis, right? We look at our maximum velocity through a normal aortic valve, which is real open, right? It's going to be relatively low. As the stenosis increases, right, we start to see that our velocity must therefore increase because we're maintaining our flow through that area, okay? And that's all the modified Bernoulli equation is showing us, all right? So how do we get to what I want you to remember and what's an essential equation is that the change in pressure between two chambers or two areas is equal to 4V squared. So how do we get to that, right? So the kinetic energy of blood is equal to 0.5 times the density of blood times the velocity squared. I don't care that you remember that. I just want you to know, where does this all come from? Okay, so if we go back to our previous slide, we see this here, right? 1/2 the density, right, is 1/2 the density of blood, okay? And based on what the true density of blood is, this becomes 4, all right? So if we want to maintain, we have our K1 and P1, and we're rearranging, right, our equation. We have the change in P is equal to 4V velocity squared, this one here, minus 4V1 squared, okay? What's essential for you to remember that is if the velocity here is very, very low compared to V2 velocity, so if the velocity in this chamber is very low, it's negligible. And we just don't care what it is because it's not going to affect our calculation. So it can be disregarded fully. And so that's how we end up with 4V2 squared. Right? So that's the derivation of the Bernoulli equation, canceling out, the viscous friction, et cetera, that we don't really care about, or the acceleration fraction, which we don't care about. We bring it down and we derive it down to 4V squared because we're disregarding V1. Now, last week, remember, we had this very difficult question talking about someone who had pulmonary stenosis, and we're calculating their PA systolic pressure based on their tricuspid regurgitation. Don't worry, we're going to do that question again, right? Because of the pulmonary stenosis, which causes a high velocity at V1, we therefore can't disregard that. So remembering that if you have something like tricuspid stenosis or pulmonary stenosis, we have to account for those later in our calculations, and I'll show you how to do that, right? So pulmonary stenosis, tricuspid stenosis, I want you to remember that we have to remember that these are going to be a component in our calculations. But normally, we just care about the maximum velocity because it's so much bigger than V1, all right? Okay. So let's go through some actual practical calculations and how we use them. So we spoke last week a little bit about right atrial pressure, and we all kind of use this on a daily basis, even if we don't understand where it's coming from. So in a spontaneously breathing person, and you take a big deep breath, you're going to alter your blood flow that's going into the thoracic cavity by making negative pressure in the thorax, right? You're going to allow for the gradient, right, to be lower in the thorax. The pressure in there is less, so blood flow is going to come downhill into a lower pressure system, which is the thorax. So that respiratory variation is what we're going to use to help estimate our right atrial pressure. So basically, we're trying to see what the central venous pressure is, and we're assuming that's equal to our right atrial pressure, okay? So if we have an IVC that's less than 2.1 centimeters, right? So very small, and it has greater than 50% respiratory variation, right? Then we assume our CVP is low, is 3. If we have an IVC, which is greater than 2.1 centimeters, and there's no respiratory variation, right? We assume that our CVP is high, 15, right? If we have one of two things, there used to be a breakdown like 3, 5, 12, 15. The only other number you need to know is 8. So 3, 8, and 15. If your IVC is greater than 2.1 centimeters, right, and it has greater than 50% variation, that equals a CVP, or a right atrial pressure, of 8. If you have an IVC which is less than 2.1 centimeters, but there's less than 50% variation with respiration, changes in interthoracic pressure, that's also going to give you an estimation of 8 millimeters of mercury. So these are the numbers that you need to remember. This is stuff that we do on a daily basis when you're looking at IVC measurements in the ICU, okay? I want you to know that it's not incredibly reliable as a true estimation of your central venous pressure or your right atrial pressure. you can, if you have people with central lines in and you check their CVP, you're going to notice that it is a little bit different than what you're seeing on your ultrasound. So, but the reality is it's all we've got, okay? So it can underestimate your right atrial pressure significantly, and it's important to know that it may, but we need this number when we're calculating our other hemodynamic parameters, okay? So take it with a grain of salt, but you still have to use it because we don't have a better solution, okay? Now, when we're measuring our right atrial pressure, there are a couple warnings that I have down here. The first is with mechanical ventilation, we're not going to have that respiratory change in the thoracic pressure, and therefore it's going to be even less reliable than in your spontaneously breathing person. So using it as an estimation for right atrial pressure kind of goes away a little bit. Again, it is all we have, and so we use it in our calculations, but remember that that's a variable that's a little bit limited. So I would say if you have a central line and you have a reliable right atrial pressure, why not use that? The second is something called pseudo collapse. So let's say that I have my IVC in my view, right? It looks like this. Patient takes a big deep breath, and now I have my IVC and it looks like this. Well, how do I know that I'm still looking at my IVC? If I am initially looking right through the middle of my IVC with the ultrasound beam, and they take a big deep breath, right? And their IVC moves in relation to where their body is, or my probe moves in relation to where their IVC is. And now I'm catching this area here. I'm going to underestimate the diameter of my IVC, and that's called pseudo collapse. So it's important that we do our best to try to get the biggest diameter that we can find reliably, and we try to get multiple different views when patients inspiring or expiring to get the best measurement. Okay, so those are the areas where you can have some incorrect measurements. All right, so let's move on to our PA systolic pressure. Okay, so this is, so some of the slides, when they move over to the iPad, they change a little bit in their size. So some of the calculations may be a little bit less visible. So basically, this equation is very easy. Your PA systolic pressure, yeah. Can they hear now? All right, cool. All right. So our last time through this, which probably won't be on your board exam, is that there are a couple times in which calculating your PA systolic pressure via your tricuspid regurgitant jet can be faulty. Those are primarily AFib, and if you have a sinus arrhythmia with tachycardia, and that's because you have beat-to-beat variations in your stroke volumes. And if your stroke volume or the volume within that chamber is lower, then the pressure is also going to be lower, and your tricuspid regurgitant jet is therefore going to be lower. And so with these patients, we need to make sure that we are measuring multiple beats. The textbooks will tell you 8 beats. For the most part, you need to do at minimum 3 beats, measure your velocity, and get your average over that period to have a more reliable, true calculation of your PA systolic pressure. The next component, which is really, really important, is for any patient that has right ventricular outflow stenosis, so whether that's pulmonary artery stenosis or if you have a subvalvular stenotic region, that there's increased pressure across that gradient, right? So if there's high pressure on that back end, right, at the pulmonary artery as the right ventricle is trying to push blood out through the pulmonary artery, that's also going to contribute to the backflow through the tricuspid valve. So if we really want to know what our true PA systolic pressure is, we have to subtract the component of that gradient that we're measuring, right, at the tricuspid regurgitant jet from our true calculation. So let's say you have a gradient of 36 millimeters of mercury across the pulmonary artery, right, because it's stenotic, but you calculated your PA systolic pressure based on your tricuspid regurgitation as 76, let's say. You need to take that 76, which is what you think your PA systolic pressure is, but take away the stenotic component, and so subtract 76 from 36 from 76, giving you a PA systolic pressure of whatever that is, right, 40. So that's an important thing. We're going to go through that in a question, actually 2 questions, and that was the question we had last week. That was pretty tough for everybody, right? And this is the reason why. So PA systolic pressure pitfalls and what can give you some underrepresentations or overcalculations or undercalculations. So if you have a compensated right ventricle, right, meaning you have chronic pulmonary hypertension and your right ventricle is really thick and beefy and it's used to high pressures, it is going to be able to compensate for that gradient, right? And it is going to underestimate your PA systolic pressure. So it's so strong that it's able to push that blood flow through and actually not cause more regurgitation, right? So we don't want that right ventricle to compensate, get stronger, have higher volumes, and therefore contract more, pushing blood forward. And now you have less blood coming back through your tricuspid valve, right? And so therefore, when you calculate your PA systolic pressure off of that TR jet, it's going to be less than what it truly is. Does that make sense? Because your RV is so strong, it's able to compensate and push blood forward through the pulmonary artery, and therefore you don't have blood going backwards through the tricuspid valve. And so your calculation using your tricuspid regurgitation is going to be less than what the true PA systolic pressure is. Does that make sense for everybody? You're saying yes, but you're no.
I would have thought the TR jet would still represent the increased pressure regardless of the RV.
No, so if you have remember how your right ventricle works, right? Your right ventricle, right? This is your right ventricle here. It moves upwards this way and over this way. And the way that the anatomy is set up is to optimally push blood flow out of the ventricle, right? So if you have a compensated ventricle that's really thick, right, and maintains its anatomical structure, when it contracts, the blood flow is going to want to go in that anatomical direction. The only reason it would go backwards through the tricuspid valve is if this tricuspid valve orifice here that I'm circling is really widened, right, anatomically, or if when the blood flow is trying to go out in the right direction, it can't go anywhere, and it's got to come now backwards through this way. Okay, so because of that, because your RV is so strong, is able to push blood out more reliably than in a patient who's not compensated, you're going to have less regurgitation, and therefore you're going to underestimate your PA systolic pressure. All right. If you have somebody who has severe tricuspid regurgitation, you're going to have very quick equilibration in pressures in the two chambers, right? We've talked about this a lot, that if there's a lot of regurgitation, you are going to reach your velocity fast. It's going to cut off, and then you're going to have a slow recovery backwards. So if you have very severe TR, you may not be able to truly see what your high velocity is going to cut off really early because the two chambers become equal all of a sudden. And sometimes you have something called ventriculization of the right atrium. If you deal with a lot of regurgitation, that right ventricle, the right atrium gets really beefy and strong and actually looks like the ventricle. So the two chambers almost act as one. So if you think about patients, that we've had that have endocarditis with very, very severe TR, right? What happens? They just do a valvulectomy sometimes, right? They just take out the valve because that valve wasn't doing anything anyway except seeding more bacteria. Now, do these patients do poorly? Yeah, a lot of them do poorly, right? Because they're pretty sick in general and they have horrible pulmonary hypertension already, and developing pulmonary hypertension is already going to increase your mortality, right? But they're a shining example of if you have very, very severe TR, that the two chambers start to really just look the same, right? So if we're trying to measure the maximum velocity, well, if there's no real velocity between the two chambers, because they're basically one chamber, then what are we actually calculating, right? Really nothing. And then we spoke about IVC measurement and our problems with that. Our IVC measurement can overestimate or underestimate our right atrial pressure significantly. So less reliable, but it's what we got. So use it. So let's move on to PA diastolic pressure. These are some of my favorites, and I use them a lot. And they're based off of your tricuspid regurgitant jet. Okay. So if you look down on the bottom right hand of our screen here, if you get a view, your parasternal short axis view, right? And you are seeing at the top of your screen your left ventricular chamber with your two papillary muscles, your septum and your right ventricle here, right? If you now take your probe and you start to flatten it out onto the body, so you're trying to look more anteriorly, right? what are we going to see? We're going to start to see our mitral valve, right? And then if you keep fanning up forward, you see your Mercedes-Benz sign of your aortic valve. If you're able to rotate your probe a little bit to the patient's ipsilateral shoulder, so their left shoulder, you start to pull out the right ventricular outflow tract, okay? And here we see our pulmonic valve, right, and our main pulmonary artery. Now, Kim did a really great echo yesterday in a patient with severe pulmonary hypertension, and she's smaller, and she had very good windows, and we were able to get great views of not only her main pulmonary artery, but her main right and left pulmonary arteries. And so if you find where your valve is, you're able to measure, just like you did your left ventricular outflow VTI, you're actually able to measure your RV outflow tract as well. And so this is where we start to see regurgitation, so blood flow going backwards, right, during diastole towards the probe. And so therefore we're going to have a positive deflection in our Doppler here, okay? Now at end diastole, where on this, if this is 0.1, this is 0.2, and this is 0.3, where on our regurgitant jet are we going to be at the end of at our diastolic phase, the end diastolic phase? You have a 33% chance of getting it correct by just saying a number. 3. Okay, good. So this is where we're going to be measuring our PA diastolic pressure, because we want to measure what is the pressure gradient at that exact period of time where I'm trying to measure the pressure. So at the end of diastole, we have equilibration between our main pulmonary artery, right, and our right ventricular outflow tract, or our right ventricle. And so we can use this gradient here, this velocity here, using our modified Bernoulli's equation that we talked about. That's where the chambers equilibrate as 4v squared. And now we still have a component of our right atrial pressure pressing back up against all of that. And so we add our right atrial pressure to that, and we get our PA diastolic pressure. Does that make sense for everybody? Okay. So there's one time when this is less reliable, and that's in very severe pulmonary hypertension. So if we have very severe pulmonary hypertension, right, with severe pulmonary regurgitation, and now we have blood flow, let's see, right, that's our main pulmonary artery and our RV out. This is RVOT. This is our PA. If we have blood coming back through here and we have very, very bad tricuspid regurgitation, are they going to equilibrate? The chamber's going to equilibrate very quickly or very slowly? Quickly, right? So what happens is our velocity backwards, right? Because that's all this is measuring the velocity going backwards, is very rapidly fast. It's wide open, and all of a sudden, boom! All that blood flow goes very quickly, and then the blood flow stops, right? Because the two chambers are the same. The blood flow is not going down a path of least resistance anymore because it's the same, right? It's a closed circuit. So this here, which is nice and slow, which is as the chambers are starting to equilibrate, here is much faster, right? So your blood flow basically cuts off. And so we can actually underestimate our PA diastolic pressure in very severe pulmonary regurgitation because we can't even measure where this area is because the chamber's equilibrated so quickly. Does that make sense? All right, cool. Now, interestingly, we can also use the same regurgitant jet to calculate our mean PA pressure. And admittedly, there are like 4 or 5 ways to calculate your mean PA pressure, right? This is probably the easiest way to do it, right? And probably the way that you're going to be tested on your board exam. And basically, we're just going to be measuring at our peak velocity. So when we reach our peak velocity very early in our regurgitant jet, okay? And we would just use this number. We'd go 4v squared plus our right atrial pressure, right? And that's going to give our mean PA pressure. Right? So the same thing. Now, why would constrictive and restrictive pericarditis cause us to not have reliable measurements here? So where are the great vessels in the pericardium, or are they outside of the pericardium? They're outside of the pericardium, right? So in a patient who doesn't have pericarditis or a restrictive or constrictive component of that, we can say that the thoracic pressures are the same whether you're a great vessel just outside the pericardium or a chamber just within the pericardium. But now we have another component, which is this pericardium, which is constrictive, and therefore our pressures inside are going to be very different than our pressures outside. No longer can we assume that they're under the same pressure system. Now they're under two different pressure systems. So that's going to alter the flow through your tricuspid, through your pulmonic regurgitation, because you're now going from something outside of that restricted chamber to inside that restrictive chamber, and you can no longer assume a pressure similarity between the two. Does that make sense? Okay. So I don't think you need to memorize these, but I want you to know what they are because you may read them in textbooks. So there's 4 other major ways, but these are the 3 major ways to calculate your mean PA pressures. So you can either do 90 minus, and then this equation of 0.62 times your acceleration time. And remember, we spoke about our pulmonary artery acceleration time in 2 separate lectures. And that's this area here, looking at your pulmonic artery outflow tract, the same thing we just looked at, right? Your pulmonary artery here, right? Your RVOT. And we're watching the velocity come out this way, right? Going away from the probe, so a negative deflection. The normal time it takes to go from the opening to the peak is usually what, 120 to 130 milliseconds, right? If you're less than that, it means that we're equilibrating faster, right? So there's a high pressure in the pulmonary artery. There's a high pressure in early systole in the right ventricle. When the right ventricle pushes blood out of that right ventricular outflow tract, right? If there's a high pressure gradient in the pulmonary artery, you're going to meet your maximal velocity very quickly, right? And so you can use this as a way to calculate your mean PA pressure. I would say I don't really use this at the bedside, mainly because the calculation's a little bit more tedious. I will say what you can do if you want to practice this is you can use another equation that people will often use is instead of using 90, they'll use 80 minus 0.5 times your acceleration time, okay? And that's a good way to kind of give you some kind of relative estimate, all right? The other way that we can do it is we can just say, I'm in diastole 2/3 of my cardiac of my cardiac cycle. I'm in systole 1/3 of my cardiac cycle. So if I've calculated my PA diastolic pressure by my regurgitant jet, right? Remember here, 4V squared plus right atrial pressure. And I say, my PA systolic pressure by my tricuspid regurgitant jet, let's say it's 3 here, is 4 times 3 squared plus my right atrial pressure. I can just take 2/3 of this, 1/3 of this, and that will give me my mean PA pressure. That's another way to estimate it. We did a question a couple weeks ago doing the same technique. And then the last way to do it is you can actually get the VTI of your tricuspid regurgitant jet and use that as a way to calculate your mean PA pressure. So it's basically 4V squared and the V is your VTI plus your right atrial pressure. I would say I've never used this. Even if you look at most of the articles on using echo to calculate PA systolic pressures in the setting of pulmonary hypertension, even the authors there say, this is a relatively new technique, not used incredibly often. But I want you to know that you can actually do that as well. All right. But your main things that I want you to remember are it's your 4V squared of your peak regurgitant systolic and 4V squared plus right atrial pressure of your end diastolic regurgitation jet. Okay.
Does the constrictive or restrictive pericarditis also affect your PADP and KSP?
Not as much as your mean systolic, because eventually you'll equilibrate between the two chambers. It's going to be less influenced, because if you have a high pressure externally or a lower pressure, if you have a lower pressure externally, it's going to be hard to meet a very quick, rapid velocity. So let's say I have my chamber here, right, and my vessel's out here, right, and this is high pressure within the pericardium, and the low pressure, right, in the thoracic cavity outside of the pericardium. it's going to be harder for me to push blood flow back here. And so this area here is going to be underestimated, right? Because I can't meet this velocity. It's going to be a more slow, tedious velocity. But eventually, that velocity will slow down, equilibrate, and this will be a little bit more reliable. So your mean PA pressure is going to be the major problem, okay? So again, this is just understanding the physiology of why things happen. So when you're studying for your echo boards or you're studying echo in general, right, we use it as a way to understand our hemodynamics, not just to be echo boarded, right? And if you understand what's happening, you don't have to memorize all these numbers. You can you just start to get it more. And so the more scans you do looking at these things and kind of saying, hey, why does this person's scan look a little bit different than this person's scan, and try to bring your physiology into it, it'll make it more understandable than just reading a textbook and trying to memorize and regurgitate that information. That's just, I think, for my personal opinion, is that's too complex for me to be able to do. All right. So let's run through these these questions in about 15 minutes. If we don't get through all of them, that's fine. These are a little bit harder than I think a lot of the questions that we're used to. So again, if you don't have the answers, if you don't know every single thing perfectly, that's okay. That's a failure on you, not on me. So what is the PA systolic pressure of this patient with pulmonary stenosis, right? So big word here, right? With a peak tricuspid regurgitant velocity of 4 meters per second. So it looks like this, right? This is 4 meters per second. And the peak velocity across the pulmonic valve is 3 meters per second with a right atrial pressure of 10 millimeters of mercury. So while we calculate, let's talk about it. So what do we care about? I'll do the numbers if you want to talk me through it.
4p squared on the pulmonic, TR, so 4 times 4 squared.
Okay, 4 times 4 squared. Plus 10, okay. That gives you 74, okay.
You have to subtract it from 4 times 3 squared.
Okay, so now we have something else that's contributing to the regurgitation. So we have to take that out of the picture to get our true PA systolic pressure. So if our pulmonary stenosis gradient is 4 times what? 3 squared? Plus right atrial pressure, right, is what? 38. So would I subtract 74 minus 38? 36. Good. So our number would be here. Cool? Does that make sense to everybody? So does that drive that home a little bit more? That for the most part, you can use your tricuspid regurgitant jet to calculate your PA systolic pressure, unless you have pulmonic stenosis, and then you have to compensate for that. Good.
When you do the two-thirds PADP plus 1/3 PASP, you're using the tricuspid regurgitant for both of those.
No, your PA systolic pressure, you're using your tricuspid regurgitant jet. For your PADP, you need your pulmonary regurgitant jet, right? You need the end of it, so that velocity that looked like this.
Yeah, got it.
You're using this area here, because this is a little bit less reliable based on things. If you don't know what else is going on within the thoracic cavity, it can be a little bit harder to truly calculate. Good. All right. A 21-year-old man with dyspnea on exertion and an enlarged pulmonary artery on chest X-ray underwent TTE. The study revealed patent ductus arteriosus, right? Everyone's like, I'm not answering this question, right? This is the data that you have. Which of the following is true? So what if I gave you a hint that we talked about QP, QS earlier? So what do we want to do here?
Calculate the stroke volume at left side.
All right, so let's do left first. Okay, so what is that? So our left side, our diameter is 2, right? So how will we calculate our area?
Pi times 2 squared.
1 squared, right? So 2 divided by 1 to get our radius squared. Okay, times 31.
About 90.
Okay, but do I care about something else too?
So I guess this time you can't assume the other side is 0.
Heart rate, right? Times 81, right? And that equals, I'll give you the number. That's going to be 7.8. All right? Liters per minute. Now, our right side is going to be what? Pi times 1.25 squared. Okay. 80. Good. So remember here, look, our VTI is less here than in the left ventricular side, right? And we would expect that because we see that there's a difference in the diameters, right? That makes sense? Okay. So this number I'll give you is 4.7. All right. Now this is where it gets tricky, right? So which side is QP and which side is QS in this patient? I'm leading you. So is this side QP? Is this the pulmonary flow? Or is this side the pulmonary flow? The right side is the pulmonary flow. In a patient with a patent ductus arteriosus?
I thought there'd be more pulmonary.
Look, we're going to suffer our way through this. And people at home have their feet up and they're just like, oh, look at these.
Oh, so where you're measuring it, I guess the PDA brings flow back in after that point.
Exactly. So what is a PDA? So a PDA is a connection between, if you have the artery, right, and you have your pulmonic artery here, there's a connection, right, between the two after your left ventricular outflow tract, right? So, but you're measuring before. So they're actually reversed. So you can assume that all the blood flow that's coming back to the right ventricle, right, is the systemic circulation, right? Because that's all the blood flow that's been, it's also incorporating your shunt fraction as well, right? So your QP is actually the left-sided measurements, and your QS is actually your right-sided measurements, because you're just measuring after the fact now. You're saying, oh, that blood, you're not measuring the blood flow that's about to go to the systemic circulation. You're now measuring the blood flow that's returned from the circulation because your shunt is after your left ventricular outflow tract. The opposite is true in the setting of a VSD, right? If you have a VSD that's shunted, now your systemic circulation is going to be what's measured going out of your left side. So it all depends on where your shunt is when you're calculating your fraction. Does that make sense? So again, this question should make you feel nauseous, right? It should make you want to quit all of this, right? And it's fine, because I want to be very honest with you. I've done this question like 10 times since I took, like when I took the boards and then now, and I only know it today. Okay? Right? So I want you to know that this is, that putting your brain behind it is really hard, but you just have to remember where the shunt is. All right. So which is the answer here? So systemic blood flow is 7.8. Is that true? No. Yanika's making us nauseous. All right. The ratio of pulmonic to systolic blood flow is less than 1. No, right? Good. Stroke volume entering the lungs is 38 meters per. So all these questions are just seeing whether or not you flip the two. That's all they are, right? Because the stroke volume entering the systemic circulation is that. Patient is cyanotic in the lower parts. Is that what happens in a PDA? No. Okay, good. And then, here we go. The ratio of the stroke volume through the left ventricular outflow tract and the stroke volume through the right ventricular outflow tract is equal to the QP-QS ratio in this patient, right? That's all we were trying to determine here. Okay? Yeah, of course. Good.
Is that statement always true?
No.
No, in this patient because of where the shunt is. The shunt is after your measurements of your outflow tracts.
PSD, your QP would be your right side and then your QS would be your left side.
Yep. If this was a VSD, if you had a connection between...
then it would be opposite the inverse of this ratio?
Yep.
Okay.
If you had a VSD, if you had a connection here, right, then you could truly account for your systemic flow being what's going out of your left ventricular outflow tract, because all the blood is already entering before it goes to your systemic circulation, right?
Okay.
Or this way.
Right.
Okay? 39-year-old woman was admitted for severe shortness of breath and exertion. TTE shows mild pulmonic regurg. continuous wave spectral Doppler tracings of the pulmonic regurgitant jet reveal the following. So what if I draw this for you? Would that make your life easier?
Yes.
Okay. So we do our pulmonary regurgitant jet, right? We're looking at our Mercedes-Benz sign. We have our outflow tract here, our valve. We're putting our probe right here, right? And we get this. So our early diastolic peak velocity is 3. Our late is 2, right? Examination of the IVC by M mode shows an IVC diameter of 2.6 and no respiratory variation. So what's our right atrial pressure? It's either 3, 8, or 15. 15, right? Good. Done. Which of the following is true? Right atrial pressure is estimated at 6. Is that true? No. Pulmonary artery diastolic pressure is greater than 31 millimeters of mercury. So you want to calculate our PA diastolic pressure? What's the equation? Plus, right? We have to show our right atrial pressure. So 4 times which one of these? This one or this one? 2? Good. So 4 times 4, right? Plus right atrial pressure. So 16 plus right atrial pressure. So is that the right answer? 31, I'm sorry. I'm just being dumb. Yannicka's throwing shade. Okay. So here. So PA diastolic pressure is 36 minus the right atrial pressure. Is that true?
No.
Did we minus or plus? No. Good. Pulmonary diastolic pressure cannot be assessed if the pulmonic regurgitation is only mild. Right. Good. Pulmonary diastolic pressure is normal. Is that relatively normal? So I actually think it's this one. I miscalculated that. So here. So you're basically just measuring your pressures, right? All right. We have 3 more questions or 4 more questions. We'll blast through. 67-year-old male with aortic regurgitation underwent TTE examination. There's no mitral stenosis or regurgitation, right? We care about this. The following values are obtained. Okay. So you guys don't know what this is. You guys know what this is. This matters. Okay. So now we're looking at our left side, right? So what are we trying to find? So either our left ventricular systolic pressure, our left ventricular end diastolic pressure, right? Or aortic area, right? Which we didn't talk about today. And we didn't talk about pressure halftime, right? So these are a little bit advanced. I'm going to take these out. So what if I told you that we are trying to find our left ventricular end diastolic pressure, right? But we didn't go over that. So how do we find that out? It's the same idea, right? So anybody want to try to talk me through it? It's hard. Okay. So what if I just show you this? That looks like the pulmonary regurgitant jet, right?
Yeah.
So you're faced with something you've never seen before, but you have all the information from the other side. So why don't we just apply the same idea, right? Okay. So if we wanted to say the change in pressure between these two things, right, is let's say we want to find our left ventricular end diastolic pressure, right? How would we find that? So 4V squared plus some kind of pressure here, right? But it's not our right atrial pressure because we're on the other side, right? So what if I told you that you could use your diastolic pressure here, right? As that reversal agent causing that. So if we rearrange this equation, our change in pressure would actually be our diastolic pressure, right? Now minus our left ventricular end diastolic pressure. And that would equal 4V squared. Right? Because instead of it being 4V squared plus our right atrial pressure, now we're moving it to the other side of the equation, right? And so if we have a diastolic pressure of 65, right, and we're trying to find our LVEDP, right, could we do 40 times 3.7 and square that? Does that make sense? We're just doing the same side, but on our left-sided circulation, right? We're compensating for the diastolic blood pressure, the pressure at the end of diastole in the systemic circulation in the aorta, right? And now we're measuring our left ventricular end diastolic pressure, and we're seeing what that gradient is. And that's what's going to give us our LV-EDP. So this actually equals 10. So this is how you can use your AR jet to calculate your left ventricular end diastolic pressure. And what's confusing you about this, right, is what is this equal to? What other chamber pressure? Left atrial pressure, right? When we're measuring our LV-EDP, we're really just trying to get our left atrial pressure. So if you just said this to me, your 4V squared, let's say I changed diastolic pressure minus left atrial pressure here, 4V squared, right? And I took this out and I did this. Would that make you feel better? You're getting your systemic diastolic pressure, not your pulmonary artery diastolic pressure, right? And all you're doing is just using the same variables, but on the left side of the heart. But because I use the term just blood pressure, it gets everybody a little bit confused, right? So that's basically what we're doing here is we're getting our 4V squared plus our left atrial pressure, which also equals our left ventricular end diastolic pressure, right? And that equals our diastolic pressure or systemic diastolic pressure. Does that make you feel better? So all we have to do is calculate with our velocity, which is 3.7, and this ends up equaling 10. Okay. So I put this question on not because we went over it, right? It's a little bit more complex, but it just shows you already have the tools to do these really complex equations. You just have to think your way through them. All right. And then this continuous wave spectral Doppler tracing of a tricuspid regurgitant jet comes from an 18-year-old woman with pulmonic valve stenosis. The peak pulmonic gradient is 24 millimeters of mercury. Right atrial pressure is estimated at 10. Which of the following is true about this patient? So does your right ventricular systolic pressure equal your PA diastolic pressure? Well, in the absence of pulmonary stenosis, kind of, yeah, right? The two chambers will end up equilibrating at that time. So your RV systolic pressure, right, is truly equal to your right ventricle and your right atrial gradient, right, plus your right atrial pressure. Right. This is basically 4V squared, what we've been talking about the entire time, right? This equals 4V squared. Right? However, in the setting of pulmonic valve stenosis, right, we have to now incorporate that. Right? Because that's contributing as well to our tricuspid regurgitation. Right? We did this question already. Like, you know this stuff. They just worded it, and you're like, the words get me all confused. So basically, all we're doing here is saying our PA systolic pressure is equal to our RV systolic pressure, right, minus the gradient that's driven by the pulmonary stenosis. So how would I calculate that? So our number's 4 here. Yep, so 4 times 4 squared plus radial pressure minus, they just give you the gradient here, 24, right? And that is 74 minus 24 equals 50, all right? So this is our answer, right? So the only thing is, if you read these questions and you don't know what the heck they're asking, just write down your numbers, write down your equations. There's like 5 equations or 6 equations you guys need to know, and then put all the numbers, plug them all in, right? You know what's happening. So you have someone with pulmonic stenosis. They give you a tricuspid regurgitant jet, and they're obviously going to start asking you about your PA systolic pressure, right? And so all we know, the teaching point for this is when you have pulmonary stenosis, PA systolic pressure and RV systolic pressure aren't the same as they normally are in a patient. But when you have stenosis, you have to incorporate that in for the calculation. Okay? And then this continuous wave spectral Doppler tracing from a 21-year-old woman represents the flow velocity profile in the main pulmonary artery based on tracing. Which of the following is true about this patient? So we have a pulmonary artery, right? So let's go back to our images, right? Valve, RVOT, pulmonary artery, right? Mercedes-Benz sign aorta, right? So should this look like this normally? What does it normally look like? Flatter, right? Good. So in what setting do you have a rapid rise, early equilibration, and and quick descent? High pressure, right? So let's go through the questions and tell me which ones you guys think. No. Good. No. Good. Pulmonary systolic pressure is 9 millimeters above right atrial pressure. You can technically use this velocity here, but I'll tell you the answer is no. But what was the scenario in which using your PA diastolic pressure was less reliable? Using your pulmonary regurgitant jet, right, was less reliable in getting your PA diastolic pressure. Under which circumstance? Severe regurg, right? So this is just the exact image of the one pitfall that we spoke about early in the lecture. Okay. This is advanced stuff that you probably won't end up seeing on your exams. And then the very, very last question. 28-year-old man with liver disease presents with JVD distension. Which of the following is true? So what's happening here? What's this waveform look like for us? So we have early equilibration, right? And it goes right back towards normal. We don't have this normal, nice flow. So what happens when this we talk about this all the time. When there's this rapid rise and early peaking, the two chambers are equalized really quickly, right? So this is an example of when someone can have ventriculization of your right atria, right? So someone who has very severe, so you have someone with JVD and liver disease. So these both put you at high risk for what? Pulmonary hypertension, right? So it sounds like you have somebody with pulmonary hypertension based on the history that they're giving, right? And now you have quick equilibration between the two chambers, right? And so I just wanted you, the thing I care most about, we've talked about this on a couple separate lectures, is the early equilibration between two chambers and seeing this early peaking, right? This waveform, right? So burn this into your memory. The answer actually is A, but I don't care that you know that answer or not. I just care that when you look at this waveform, you say, oh man, it looks like whatever's happening between those two chambers, they're all of a sudden equaling pressure very quickly. And then this flow kind of stops, right? And just knowing that from a physiologic standpoint, then you can answer questions after that. So there's right ventricular mid-cavitary gradient during systole, no. Tricuspid regurgitation is likely mild. This is definitely no, right? Peak velocity of 2.2 excludes diagnosis of primary pulmonary hypertension. No, because remember, this is where it's less reliable because you have this equilibration in chamber, right? And now using this pressure to calculate and have a reliable PA systolic pressure is not as helpful because you basically have one chamber. You don't have a gradient anymore because they're the same chamber. They just happen to have these like screen doors that are kind of flopping open up and down, doing nothing for you, right? And then right ventricular systolic function is markedly diminished. And I would say you don't have a way to say that by any means, right? All right, that's it. This is hard.
Just a simple question on that. Was that, so the bottom, it was like the negative flow, is that just because TR jets?
This thing right here?
Yeah.
This thing?
No, the other side.
Yeah,
This?
Yeah.
the last one.
What do you mean, the bottom?
Is that the systolic?
So this is, if you look here, so during systole,
Yeah, that's
right? Your RV is contracting, and it's causing, there should be some, you have your jet looking right over the tricuspid valve, so you're not going to see forward flow, right? Because it's a chamber.
Oh, so that's the
Right.
regurg.
So you're looking at the regurgitant jet through your tricuspid valve. And this early peaking should show there's early equilibration between the two chambers and what physiologically can cause that, right? And that's what you're seeing.
Okay.
Cool.